moving into the castration-resistant space, Johann, we're lucky to have so many therapeutic agents available to us now, but this brings in the topic about sequencing and potentially therapeutic layering. What do you think the rationale is for therapeutic layering, if any, in the castration-resistant space?
Well, I think first of all, I should say we haven't got a lot of rationale to really give a very brief answer.
Yes.
And I am concerned that a lot of assertions are being made based on these trials we've been discussing, that earlier is better than late. And I want to say again very clearly that actually we have no evidence yet that earlier abiraterone is better than later abiraterone, or that earlier docetaxel is better than later docetaxel. My understanding is that both Latitude and Stampede control arm patients that died on the trial that drove those survival curves had, many of them, most of them had not had abiraterone in the control arm. So it really concerns me that patients are now getting a lot of these drugs very early on, and we're not giving them later. However, biologically, it does make sense that combinations could be better than single agents if you have the biology right. And I think, for example, radium and hormonal therapy makes perfect sense. I discussed the reasons for this earlier. You inhibit DNA repair if you give hormones, and actually if you have strong biology for synergy, giving those drugs in combination to try and improve long-term benefit is important. But we have no data, so we cannot make those claims or assertions, and we have to do the appropriate trials. And what concerns me is that we're using resource, patient resource, fiscal resource to run trials that are not really addressing the key questions in my mind. And I'm being very critical here.
Chris, do you have anything to add to that with regards to the layering and the rationale for it, or the sort of current practice in that?
So I agree with everything Johann said.
Wow, that's new.
We don't have good evidence to answer the question.
Yeah.
It seems to me that so-called therapeutic layering is a halfway house between sequential on the one hand and combination on the other. And we don't even know whether there's any benefit to combination rather than sequential. So I guess we need to answer the simple questions first.
Yeah. I guess in radiation oncology, we've been combining therapies like external beam radiation with ADT for many years, and I suppose the concept, and in many cancers, the concept of combining multiple drugs has been common practice in, I suppose, initially the lymphomas and the testicular cancer. So it's been it's a concept that's widely used in oncology. But Bertrand, I don't know if you have any thoughts on.
But I think it means, what do you layer with what?
Yeah.
Okay,
Yeah.
When it comes to a drug like radium, your trial was layering because it was radium on standard of care versus standard of care. The problem is that we're not speaking about the same standard of care. So when it comes to adding radium on top of enzalutamide, I've got less problem that, for instance, adding abiraterone on enzalutamide. We know no, it doesn't work. We have the plateau trial. So that's perfect example that, layer, it's not like a cake. You still need a rationale to add on top of the layer. So
I do think that's an important point you make, because actually people are giving a lot of Enza after Abi after Enza, and I think the Plato data for me are one more reason why we shouldn't be doing Enza after Abi or Abi after Enza. The Plato trial has shown quite clearly if you're progressing on Enza and you add Abi, there's no benefit. I think there's now a lot of data to convince me personally that we shouldn't be doing Abi after Enza, Enza after Abi, and other drugs should be used instead, personally.
But then when I see people that want to add a kind of docetaxel, cabazitaxel, then we may have toxicity coming on. So you have to be careful. So yeah, layering is intellectually very appealing, but it has very little clinical benefit demonstrated, potential economical and patient toxicity. So we have to be smart. With the exception, the historical exception, I would say, of bone-targeted therapy in general, because that makes more sense. But for the rest, we should be careful.
I think we should be careful for bone-targeted therapy as well.
Yeah, I know. I was sure you would say that.
Well, I'll just briefly say why. So you're talking, I guess, about denosumab and zeledronate.
Yeah.
So, it seems to me the evidence base for using them at all is really rather outdated. And do we know it still applies with all the current new therapies? We know that SREs are much less common now than they were when the role of zeledronate was established.
Or they're appearing at least very late.
Yeah.
And in a situation where, at the time they were developed, there was something we would never see, which is response in bone. And now with Abi and Enza, and modern technology, we see fair proportion of patients who have complete response in bone. So if they don't have any bone metastases, they don't need,
Yes.
so...
Yes, we've got much better drugs for preventing SREs
Yeah.
now than we did then, and they're called abi, enza, docetaxel, radium.